morning, everybody. Thank you for the organizing committee for inviting me to this meeting. It's actually a pleasure to be with you. I have no disclosure. I'm going to talk about the osteoporosis, diagnosis, assessment, monitoring, and treatment. Actually, the osteoporosis is a very common disease in medicine, and it's good that it's a preventable disease. So screening treatment of osteoporosis from the beginning is actually not only to make your surgery easier, but also to prevent fractures of that it may be very disabling and increasing mortality and morbidity. So in fact, we always think or believe that the spine is the window of the osteoporosis. So most of the osteoporosis diagnosis, we know it from the vertebrae, either from the osteopenia that we are seeing in the X-ray or from the compression fracture. Without any doubt, the vertebral fracture is the most common clinical manifestation of osteoporosis. And as you know, that there is an 8-fold increase in the age mortality, adjusted mortality, when the patient has vertebral fracture. More of vertebral fracture can happen, almost 5-fold. More hip fracture can be happen in the patient with vertebral fracture. Plus the major impact of the quality of life, including the back pain, loss of height, and distorted body imaging. As the patient advances in age, as there is increase in the number of fracture. You know this very well, that's most of the fracture happen in the mid-thoracic and thoracolumbar junction. Type of osteoporotic fracture, I'm sure you will know it very well. The symptoms and signs of vertebral fracture can be asymptomatic, and the pain, it can be tolerable or incapacitating. There is a height loss that we always ask in our clinic, and if it's more than 6 centimeters of height loss, that gives almost 95% of specificity of vertebral fracture. Plus the kyphosis that it may patient presented with. The clinical diagnosis of osteoporosis is either fragility fracture in a spine, hip or wrist or humerus with spontaneous or minor trauma, or a T-score that we diagnose by the BMD of less than 2.5. The BMD is a standard test to diagnose osteoporosis for women and men more than 50 years. However, it's not recommended for the pre-menopausal women, as it's not representing the real quality of the bone, and it's not correlated very well with the fractures. We sometimes use the T-score as a list of the less than -2 to diagnose or look for the secondary cause of osteoporosis. Dr. Sadat Ali, Prof. Sadat Ali, he already talked about the diagnosis by the BMD, and we in medicine look for factor and secondary cause of osteoporosis that we always look for it. Age, previous fracture, glucocorticoid therapy, parental history of the hip fracture, all of this factor may actually help us in defining the risk of osteoporosis fracture. As you can see here, the age is very important. So with the same hip T-score, the risk of fracture in a patient with in young age is much lower than the hip fracture risk in elderly. Now we have the FRAX assessment, which is, we use it in the clinic more frequently now, using the, and the Saudi Arabia is included in the list of the country that we can measure the risk of fracture, either in the hip or major fragility fracture. This is a list of secondary cause of osteoporosis, and that's the common one, like glucocorticoid, cancer chemotherapy, cushion, hyperparathyroidism, gastrointestinal disease like celiac disease, post-bariatric surgery, rheumatoid arthritis, and so on, and hematological disease, that's sickle cell anemia and thalassemia. So when we think about secondary cause of osteoporosis, it's usually from the history and physical examination. And if there is unusual fragility fracture at certain age in young people, or if there is osteopenia in young people in X-ray, or if the patient already have osteoporosis diagnosed somewhere, he treated proper treatment, but he still have worsening of his BMD. Initial evaluation, I'm not going to do this. Dr. Sadat Ali talked about it, and I always mention that the treatment of osteoporosis, if the patient have secondary cause, may be enough, and it can be helping the patient. Lifestyle modification, calcium, vitamin D is the main thing for preventing osteoporosis. Most of the patient will be for preventing osteoporosis, the 800 to 1,000 of calcium daily, and up to 3,000 of vitamin D daily. There is lots of forms, daily, weekly, monthly, but it's very important to keep patient with osteoporosis or a high risk of osteoporosis on this medication. When we treat the patient with pharmacological treatment other than the calcium and vitamin D, and the patient have history of fracture, if the patient have T-score of less than 2.5 at the lumbar spine, femoral, neck, or total hip, or if the FRAX criteria, you measure his fracture and you find more than 3% risk of hip fracture, or more than 20% of major osteoporosis fracture, that's indicated of the treatment with the medication that we are going to mention. So this is different guidelines, the Canadian guidelines, American guidelines, AACE, IOF guidelines. Most of them, they are depending on the FRAX system. Quickly, I'm going to try to talk about the medication that we are using to prevent fracture and osteoporosis, and there is anti-resorptive agent, and we mainly think about esophageal or GI intolerance in oral medication. We also look for the atypical fracture of the femur. The ONJ is one of the important things that we look for. We always do the calcium, vitamin D, and creatinine all the time to make sure that the creatinine clearance is the normal. We're using zoledronic acid, one of the anti-resorptive. More commonly now we are using the denosumab, which is rank ligand inhibitor. We watch for hypocalcemia. We have the same side effect like the AFF and ONJ. The problem with denosumab that we cannot stop it right away because of the significant loss of bone. So patient need a long follow-up, sometimes close follow-up, sometimes arrangement with the dental clinic if the patient going for dental procedure or going for any type of other surgery that need almost close follow-up. Hormonal therapy and relaxifene, we are not using it as common as the previous slide. Anabolic agent like parathyroid hormone and Romo is one of the new medication that we are using, and as Dr. Sadat Ali, we use it for 1 year to 24 months. Then we have to put patient back on anti-resorptive medication. All of this medication help in vertebral fracture. Few of them help in hip fracture, and this is just to tell you that there is a different plan for follow-up for each medication that we are using, and different concern that we put it in our plan with treatment of patient with osteoporosis. This slide just to keep in mind that the chronic kidney disease, GI problem, patient with have maybe there's a contraindication not to use this medication, to prefer to use this medication, and we go on. Monitoring with DICSA, of course by history, make sure the patient have no fracture, doing a DICSA scan, worsening of DICSA scan by more than 5% is indicative of a failure of the therapy or not good responder. Make sure the patient is taking his calcium regularly, he's taking his vitamin D supplement, plus the medication that you choose to give, and maybe it's the time to shift to another medication or another plan. Thank you very much.